Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. It's great to be spending this time with you. On today's episode, we are discussing how to contextualize care for improved patient outcomes. Contextualizing care is the process of adapting your treatment approach to a patient-specific life context. The failure to do so is called a contextual error, which often results in a care plan that is not likely to achieve its intended aim or produce a positive outcome. There is substantial evidence and research that contextual errors are common in everyday practice. They adversely affect patient outcomes, they drive up healthcare costs, and they are widely preventable. Joining us today to discuss how to contextualize care and the role that humanities play in the physical therapy profession is Dr. Gail Jensen. Dr. Jensen is Vice Provost for Learning and Assessment, Dean Emerita, and Professor of Physical Therapy at Creighton University. Dr. Jensen is internationally regarded as a scholarly expert in clinical practice, clinical reasoning, professional ethics, as well as interprofessional education within and outside of the physical therapy profession. She has co-authored more than 90 publications in peer-reviewed journals and has co-authored 13 books, including a new edition of Clinical Reasoning in the Health Professions. She led the research team that completed a national study of excellence and innovation in physical therapist education, funded by the American Physical Therapy Association and several APTA components. Dr. Jensen holds a bachelor's degree in education, a master's degree in physical therapy, and a PhD in educational evaluation with a minor in sociology from Stanford University. On today's episode, we discuss the importance of clinical reasoning and the patient context in patient care and healthcare in general. Okay, without further ado, let's begin and let's meet Dr. Gail Jensen. Hey there, Gail. Thanks for joining me this week on the Healing Pain Podcast.
Yeah, thanks, Joe. I'm delighted to be with you and share some thoughts, which we both agree with, I believe.
It's an honor to be speaking with you today. You've been in the physical therapy profession and, of course, clinical education for many, many decades. You're known as a leader in education in physical therapy and really the health sciences in general. So I'm interested, the word context is oftentimes thrown around so much, and it's especially thrown around in the world of chronic pain. Oftentimes you hear things like pain is contextual, right? And I think providers are starting to get an idea of what that really means. Although when we look at kind of the myriad of chronic health conditions that we see, both physical and mental health conditions, and we know that those two things are inseparably interconnected now. I think a lot of the work and kind of the direction you're starting to head is how do we bring together the clinical side of practice together with the academic world so that we can improve the patient experience and obviously clinical outcomes. How did you become interested in this topic?
That's a great question. And it's a question related to, it does matter where you go to school. That's what I would say. That I was just really fortunate to go to an entry-level master's degree program at Stanford University. And when Stanford's master's degree program was in operation, those of you may know about Catherine Shepard. Kay was a huge influence on the curriculum, and the commitment that program had to the integration of the social and behavioral sciences as well as the physical and biological sciences was foundational in the curriculum. And those were the values that were shared by faculty and promoted in the curriculum. I mean, I had a course in organizational behavior. We, certainly had a course in cultural, psychosocial elements, pushing beyond communication. So setting the stage and putting that in place in what I call the implicit curriculum as part of your professional identity and formation is incredibly powerful and long lasting. So I've always seen it like that. And, my clinical area is in musculoskeletal. If you don't understand the person you're working with, you're not going to be very successful.
So your postgraduate training included the biological along with the social and environmental, if you will?
Well, that was my entry level degree. My undergraduate degree was in education and physical education and health. So I, instead of getting a second bachelor's degree at that time, I got a master's degree, which was one of the reasons why I was attracted to being part of the foundation faculty for the first DPT program at Creighton University. To me, it made sense to think about preparing therapists at that level in terms of societal need.
Yeah, and it's so interesting because what you're talking about now really is an evolution kind of the biopsychosocial model, but you're starting to really, let's use the word, contextualize it for physical therapist practice in a way.
Yeah. The other thing I would say is that, and this was an aha that we got our research team we did a national study of excellence and innovation in PT education. We published a couple of papers in physical therapy, and we published a book, Educating Physical Therapists, published by SLAC. But it was a Carnegie-like study. So we met with Lee Schulman when he was president of the Carnegie Foundation, and he said to us, and this was, Terry Nordstrom, Lori Hack, Jan Guyer, Elizabeth Mostrom, all really experienced people. But we had never thought about this. He said, you're in a very challenging profession. You're in a profession of human improvement. Just like teaching, you don't have complete control over your outcome. We don't have complete control over students, and we don't have complete control over patients. And he showed us to David Cohn's work, and David's written at the University of Michigan about how people who work in these caring professions, these where you don't have complete control over the outcome, that's hard work and complex work. So you really have to understand the people you're working with. It sounds simple, but it's not.
It sounds clean when you're in school, right?
Yeah, right.
And then you get out and you come out of school and you realize, wow, this situation or this context that this patient is in is not so clear cut and dry, basically. And what does understanding patient context really mean? So let's start to dig into that a little, because we mentioned context a while, and this whole episode is going to revolve around that. So what does understanding patient context really mean?
Well, we throw words out like, the lived experience. What is that? And at the heart of it is really a deep, active listening. It's not just the term. And I think physical therapists, we have a unique skill set here, in that our observational skills, I think, are exquisite. They're very good, and they're very much part of reading the patient in across all the systems. So, but context is not. It's not we use it kind of as a throwaway. Now, social determinants of health. Oh yeah, I know about that. Check, check, check. Oh, I know it has to do with upstream factors. We kind of treat it as something that, oh yeah, I know about it. I need to pay attention to it. But what does that really mean? I think that's the ultimate challenge. Now, there's, and I shared with you this paper, which was fascinating, on contextualizing care, arguing that understanding the patient context in a meaningful way is an important part of clinical reasoning. It's understanding the patient, where the patient's coming from, what they value. Now, we have a tendency to say, oh, we're going to call that motivational interviewing, and here's the skill set or the tools you need. Again, I go back to that deep, active listening, connected with what we know, certainly, and how we navigate and ask those meaningful follow-up questions, understanding what kind of support system, understanding the elements of the ICF model, not everything. If you do the whole ICF model, it takes you an hour, right? No, what does it mean to have support? What does it mean to engage in something? So it goes back to, I think, a very high level of expertise that's needed to do this. And the other thing I'd say, Joe, is, I go back to our study of expert practitioners that Lori Hack, Jan Guyer, and Kay Shepard and I did, that we saw expert clinicians do this well. You're one of those. I should ask you, How did you come? Why is it that expert clinicians do this so well?
I think
I am asking you that
right.
question.
No, this is the flipped interview now with Gail Jensen.
Right.
I think part of it is this is my lived experience of being in the profession, working with other professionals, and also hiring and training other professionals. When someone comes to the profession with their own lived experience of a health crisis, so to speak, whether that's you tore your ACL in high school and that was a shock to you, or whether your grandparent had a massive stroke, that lived experience has now informed the rest of your life, whether you become a healthcare provider or not. And then what's encapsulated in that is how you then are able to relate to someone else's lived experience, even if it's difficult for you at times to relate to someone's lived experience because it may be far from your current experience. And there's a lot of, we've used the word lived experience now a lot. And I think you said it very pointedly in the beginning. We throw that word around. There's not just one lived experience. Every person on the planet has their own unique lived experience. And I think there's curiosity that has to develop there. And that's where you're kind of bringing this conversation to light for all of us, is that the social sciences in some way are embedded in what we do, whether you realize it or not.
Yeah, and they're not just integration of the humanities, and which is really a hot topic in medical education. It's not just reading a poem or going to a museum, but it is the integration of the story and the narrative, which I think expert clinicians, they get the story.
Mm-hmm.
And they are skillful in asking follow-up probing questions to understand that story. It's not that, and we know novices are very, very rule governed, so they're going to ask everything, right, that's on the exam that they're supposed to do in the examination evaluation process. And so how do we move that along? And the argument, I think, is I'm very fond of the frame document that came out of medical education, and I have a table in the Sarah Soley lecture, which will be published in the Journal of PT Education, I think in the winter issue coming up, and it's from the frame document. And so they make the argument that it's the integration of the arts and the humanities into health professions education that's important. So how do we help tie that to things that we have to have, the knowledge that we have to have? So it's the integration of ethical reasoning. It's they have this wonderful they call it perspective taking, but how do you see things from multiple frames of reference?
Mm-hmm.
That's really critical if you have any kind of moral or ethical situation versus this is my view. Well, how do you see it from other people's view? And how do you have, to what your point, Joe, was that important, critical self-reflection, personal insight, and those non-cognitive parts of who you are really important. Clinical reasoning is all about your cognitive part, but it's also your non-cognitive abilities of how you have that kind of growth mindset and inner drive. And then, probably most importantly is how we see what our professional role is in social justice and advocacy. And one thing we found in the expert clinicians, and this again was a very strong finding, is what we called moral agency. And so those master clinicians, those expert clinicians, regardless of whether they were working in geriatrics or pediatrics or neuro or orthopedics, they really went the extra mile. They didn't judge, they withheld judgment. So they didn't call the patient, a poor historian, workers' comp case, I'm going to discharge, they're not adherent, they're not doing what I want them to do. No, they saw that as their shared responsibility in trying to manage the complexity of the situation. That's central.
So in a lot of ways, this brings together the art of caring for another human with the science of clinical reasoning that we learn in practice. So it's the art of the humanities with the evidence base of the science.
Yeah, and I would say that the art of it is part of the reasoning process. I think we're so quick to go to it's just easier, the cognitive way. Oh, it's about dual processing, fast and slow thinking, right? It's about cognitive load. It's like, yes, but it's also about these non-cognitive things. Situation awareness. That's probably one of the most important elements in your ability to see context. Are you aware, and are you asking questions to make yourself situationally aware of what's going on with this patient in the world they live in?
So two things I'd like to just kind of chime in with is one, everyone knows that I've studied and teach acceptance and commitment therapy. And within that framework, there is a number of exercises around perspective taking. It's not only your own perspective taking, but being able to take the perspective of others, which in our very me society, oftentimes that's a skill that is lacking or is missing from someone's emotional intelligence and awareness, so to speak.
So are you asking me how we facilitate that?
Well, what I'm really thinking is that there's a lot of mindfulness that is involved.
Yeah.
In this type of
Yeah.
care, because
and somebody who I think is one of the most thoughtful writers in this area is Ron Epstein. I'm sure you've read his work. Ron is a internist and also works in oncology at University of Rochester. He wrote the book Attending, but he wrote a classic paper called Mindful Practice in 1999, I believe, Academic Medicine. And he talked about how often you see learners that are quite mindless and they're so focused on the task that they're not present. Mm-hmm. See, it's the other thing that we found early on. This reminds me, we did some pilot work before the expert practice study, and we looked at what we called master clinicians. We published a couple of papers on that, on the pilot work. And one of our first observations was with master clinicians is they did not allow interruptions. So there was nobody coming in there, hey, I need the ultrasound, right? They were present in every way, shape, or form with their patient. They did not allow interruptions and that was in contrast to novices who were a little bit like squirrel, right. Here we go.
Really,
I think the question then is, there are these elements in the master adaptive learner model around what they call, the battery power, but you mentioned before, curiosity. How do we do coaching and mentoring to facilitate curiosity, or do we drive it out of learners? Growth mindset, resilience, and certainly the organizations in the healthcare system is not very friendly. It's somewhat broken, and I think that's a challenge to all health professionals right now.
That's an excellent point, because oftentimes providers ask me, how do I start to use pain education, or how do I start to use some kind of cognitive techniques, when they're so focused on really being task oriented, right? I have to give them the exercise. I have to do this certain technique, when really what you're saying is start to think broader than that. And that may be how we start to move toward contextualizing care for people.
Yes, I let me reflect on one of the experts in our expertise study was Peter Edgelow, and I had the honor of observing him and collecting data. And Peter, if you know, Peter passed away a few years ago, but an exceptional manual therapist who later in his career really focused on getting a patient portfolio where people were sending him patients who were experiencing chronic pain, in the San Francisco Bay Area. So Peter, an exquisite clinician in how he worked with patients in a very incremental, thoughtful way. And he was one who said again and again, it's my responsibility. It's a shared responsibility here, finding ways for this patient to manage their pain and suffering, and we can figure it out. Mm-hmm. Never gave up. Mm-hmm. Just incredible. And I think intuitively, he probably used many of the strategies that you're talking about. And I think the challenge for the profession is how do we develop, how is it both and versus our emphasis? And I think we just, as a profession, we kind of suffer from this. We're people who like to move or active, or, so it's like, oh yeah, let's do the task. But we need more integration of, well, wait a second here. It's not just that. It's not just the exercise and not just the mobilization. It's not just, it's more than that.
So I have a thought about that.
Good.
Because I think about things a lot. With our profession being so focused on physical function, which is important, obviously, it really is one of the prime goals that we have and goals that our patients have. But I also wonder if we need to, at times, tend to our expectations of what can happen in let's say, an 8-week clinical encounter that we have based on, insurance visits, so to speak. So patient comes in, they're approved for physical therapy twice a week for 8 weeks. And in our mind, like, we want to get them back to whatever it is, walking, running, et cetera, not using a cane, whatever the patient's goal may be. But I do think there's a lot of foundation that has to be built up first at times with certain patients and certain populations, and with certain people that have a lived experience that is a little more distressing for them before we get into the, okay, we're now going to strengthen your whole body and work on functional activities. Mm-hmm. And I think that's what's missing. No one has to date, and I'm going to be the one to do this, obviously. No one has given a physical therapist a permission to say, it is okay if you just spend your time holding the space for talking with, counseling, educating, learning about your patient and their unique history before you dive into the intervention. And that's, I think the problem with that is I think it's uncomfortable for us as therapists, as physical therapists. It's uncomfortable because we feel like we have to be doing, as what you're saying, instead of sometimes just being with the patient is a better way to start to initiate contextualized care.
Yeah. I have a couple of thoughts on that. One is, first, people are going to say, well, who's going to pay for that, right? Right. You've got to. But the second is, I think, the need for. I think you do have to be careful of getting into the mental health area. That you, if you don't have the understanding or skill set, you could get into some dangerous territory. Now, I also think that, and you've written about this, the power of touch. We have really such great opportunity. Touch is meaningful touch in, therapeutic and which that communicates a lot, and we can't lose that part of the practice. Now, I think we have to be careful to make sure we don't lose that in our education side. Yes, it's great to have outcome measures, and I get that, but the importance of handling, the therapist is part of the intervention. You can't separate the therapist from the intervention. It's not just what exercise you do, and to your point. And I think that how we handle another person's body says a lot. Mm-hmm. And it's in it, in spending time with the patient. So it's in that kind of handling, thoughtful handling, that you can learn a lot. And I think expert therapists do. So I struggle with this in, with larger class sizes, and how do we communicate? How do we facilitate that kind of development? Because what I see on the residency side, which has always been quite interesting to me, I've been connected to, manual therapy, orthopedic residencies for years, is how therapists come to that because they want to enhance through deliberate practice their manual skills, and that has to do with touch and palpation and all that kind of stuff. And I don't think they were the ones in PT lab classes that sat there and did things once, but that also is a frustration to me. Oh, we've done it once. Okay, can we move on? It's like, no. So how do we facilitate the importance of deliberate practice as developing our ability as therapists to really facilitate movement? The other thing I'll say, another reflection, you're making me think back here about our expert practice study, is we worked with a couple of consultants. One was Jack Hershey, Dr. Hershey, Lori Hack's husband, who did a lot of work in decision analysis. And we had two other people from Stanford. One was Lee Schulman, and the other was Anna Rickard, who was a colleague of mine from graduate school. And they looked at our videotapes, and they said, well, this is amazing. I mean, look at, how did they know where to put their hands? How did they know how to do this movement? I mean, and they were the ones that said, you know what, movement is a pretty important part of your practice. We didn't see it because we were all therapists, but they were amazed at the kind of what they saw in the videos of, some was just a simple transfer, some was, that we didn't see ourselves. So we can't lose that.
No, and I think if you look at anything regarded to chronic disease, whether it's on the physical or the mental health side, human movement is essential to that.
Yeah.
And even the concept of the movement system, which I know Shirley Sarman has kind of pioneered in many ways. I don't even think we've gone as deep and as vigorous as we need to in that area to really start to build out really the conceptual frameworks around, okay, when I say movement system, people think of like muscles, joints, and bones.
Correct.
But obviously there are multiple systems that are interconnecting with movement. Yeah. And how do we care for movement as well as optimize those other systems so that movement is optimized as well? I wonder if we can give our listeners, give them an idea of because we're talking about context, right? We're talking about context with regard to clinical decisions. So I'm wondering if we can give them an idea of a contextual error that might come up in practice, so to speak, where let's say a clinician has evaluated a patient, but didn't take context into mind, which maybe led to a less than optimal outcome with regard to the patient outcome.
Yeah. Well, I think a common error is it comes back to not understanding what the support the patient may have, or what is their what's their sense of their ability, self-efficacy. Do they have the self-confidence to engage in whatever change, behavior change or exercise or whatever you're advising? And then do they believe that if the outcome efficacy, if they do that, it'll make a difference in their outcome? I think that self-efficacy theory has a lot to explain and has been used a lot in chronic disease. So I think the miss is if you don't understand what kind of what happens to the patient the 23 hours that when they leave you, and what's that environment like? What's their support? What are their stressors? Do they live in a neighborhood where they can't walk? Do they live in a food desert? I mean, all those kinds of, the social determinants. But then what happens if they're not successful? Then it's easy for us to judge them and say, well, that's not my problem, right? I'm going to discharge. Whereas I think the sense of moral agency is that, oh no, wait a second, I have some shared responsibility in this. And I think the system makes it hard for us, very challenging. So how do you find the additional support? Now, this is where I think you're beginning to see more attention to how important non-professionals, non-health professionals are in making communities healthier. And how do we find ways to connect that? Patients who don't have transportation, or that's really, if we continue to do all of our education kind of in the traditional healthcare system settings, mm-hmm. we're not really going to move the needle much on health. And I think we have pretty good evidence of that.
Yeah.
We're not a very healthy country, are we?
No, we're not. We're sick. We are a sick country indeed. And one of the areas that's interested me with regard to community really is peers and peer trainers and peer support, if you will.
Yeah. Yeah.
And can we educate, leaders or pillars of the community to be that bridge or bridge the gap between what we're doing in clinical practice versus what's happening in the home or work setting? Because as you said, people aren't, other than 1 hour, maybe once or twice a week, they're spending many hours on their own. Does the contextual nature of what we do in contextualizing patient care, do things like DEI and affirmative practice for LGBT people come into this when you think of it?
Well, it's an important question, I think, but I think it's how we think about probably the most important thing is equity, how we think about equity, and how we are able to see everyone as a person, we're not just treating the human body, we're treating the human. If we don't understand the human being, there's no way we're going to help the human body get better. So removing the judgment is very important. Now, one thing I would say that troubles me is I have students before in the first session we have a 3-semester ethics class, and I have them do a free write of their most recent clinical experience, and I've done this over the years, and I have to say every year there are more of these free writes from students where they share stories of what I would call disrespect or judgment coming in. And students, the other thing about students, they're like the canary in the coal mine. They're quite sensitive to moral distress. They're because they haven't been jaded in some way from practice. So they will observe pretty critically when someone is, saying disparaging things in the staff office about whether it has to do with, patients' size, physical size, or lack of support, or whatever. And often students, I think, are given opportunity in clin ed for some of the challenging patients, that have a lot going on. So I think it's symptomatic of the kind of stressors and the brokenness in the healthcare system. I'm not blaming therapists, but I think there are ways where we, and Ruth Portillo wrote about this quite passionately, that we don't want complicity, and to be complicit is to see something that is wrong and not say anything. So that non-action becomes an action. And we're very clear with students to raise questions. You can always raise questions. So I think that's really important, how we come. And Ruth also writes about respect in our book on moral action. Ruth was first author on that, and a handbook for, what's the name of it? Forgot the name of the book, but it's moral action is the first thing. And she has a great chapter on respect, and how respect is this deeper sense of being with. It's not just a core value we throw around. Core values have to be enacted. Mm-hmm. They're not just, oh, here's a list and I can take a survey and, oh yeah, I think I do all these.
That's right. They're not just cognitive, they're lived.
They're lived. And the other thing where I think we get ourselves into a little trouble, and this has been written about, is that when we think of things as behaviors, oh, you see it, you observe it. But the deeper concept here is a disposition. which comes from, John Dewey. So a disposition, this is where habits come from. So habits of hand and head and heart. A disposition is something that is habitual, so that behavior will be consistent. You will see this disposition in a behavior that is predictable. You can count on that learner to do this because they embrace the habit and the disposition. So it moves us beyond behaviors to something that is deeper. That's really important.
Do you have any sense of how we're doing in physical therapy education with these topics?
I think we're making progress. I think, we have people interested in the humanities and the ethics, and we have we've had real leaders for decades. Ruth Portillo, Laura Dolly Swisher. We've had people who have really done good work. Sarah Blankton, who's the editor of the Journal of Humanities and Rehab, I think has been just such a great indication of movement in this area. What we need is
That's a fascinating journal, by the way.
It is. It's
for people who've
journal.
Never read that, they should actually log on and read it because there's some really fascinating articles in there.
And it's open access, and it shows, Sarah's just, an old soul. She's a wonderful neurotherapist, very highly skilled, high level expertise. But, her father was a physician who cared in this area, in this way. And so she really comes from a rich tradition of that. So I think we're making progress. And I think the more we get people on faculties, and that includes bringing folks like yourself, connecting with clinicians who do good work in this area so that students can see this. It's not just, the kind of, okay, it's about sports medicine. It's about, dry needling. It's like, wait, there's a lot more to that.
There's a lot more. And I think you said it really well before, that we can't just treat the body, we have to understand the human.
Yes.
And that's across, obviously on my podcast, talk a lot about chronic pain, but really that's across every physical therapy practice area and specialty.
Yeah. You said something about the movement system. Go and read Terry Nordstrom's Sarah Soli, Habits of Heart. I mean, he's got a nice piece in there where he talks about what you raised about the movement system is not just we can't just think about it in a traditional systems view. We got to think about the human being.
Yeah. And movement's a behavior, right? So in many ways, it's a cognitive behavioral contextualized mode of living, really.
Well, I've always thought my first attraction to physical therapy, yes, I like sports, but it was really about teaching. What I observed early on watching physical therapists work is like, oh, they're teaching. Well, that's really cool. So, and meaningful teaching is like, yeah, this is great stuff. I would really like to do that.
Yeah, which somehow we have kind of lobbed that into what's called patient education. Although the psychologists use the term psychoeducation, which I think is a lot more powerful. Because it's this idea that obviously there's some psychology involved in this, but really I'm educating you so you understand what you can do, how to self-empower yourself, how to empower yourself to cope with whatever health condition is that you're dealing with.
Yeah, and to that end, the other thing I'm fond of is, we've had colleagues in our field who have done really good work and good writing in this area. Go back and read Carol Davis's stuff. Carol wrote a great paper on empathy years ago, but Carol was early on. She was at the University of Miami for several years, and I think is still emeritus from there. She was out there on the road less traveled, trust me, on the behavioral sciences, making a case for much of what you're talking about, Joe.
Yeah, I mean, psychosocial and the behavioral aspects are in CAPTE requirements now. So this shouldn't be new. I guess the question is, and you're well versed in the education side of this, should we start to look at this as like a separate class where we can bring together certain topics and concepts, or it should be something that we weave through different parts of the program? Because what happens when topics like this first come up, people say, all right, we'll have a 1 hour or a 90-minute lecture on the humanities, so to speak.
Yeah. So that it's a great question. And, I guess I'll give you an answer on both sides. Do you integrate it in a way so that it's everywhere, but yet it's nowhere? Because every decision you make about curriculum has every explicit decision has a very strong implicit message. So when you mark a course, that sends a message to students, if that's the way your curriculum is organized. Now, I will say that I'm involved in our medical school in the Department of Medical Humanities. So I'm part of small groups in both ethics and humanities. And those modules, those experiences are integrated into the systems knowledge, the first 2 years of the medical school, in such a way. So when they do a unit on neuro, we have ethics and humanities cases, discussions that are focused on that. That's quite powerful. And I think it's pretty effective. And, we're studying it. Nicole Piemonte heads this up. And Nicole, did a great talk a couple of years ago at our ELC meeting. So she's got a great paper, by the way, in the Journal of Humanities and Rehab. So I think in that case it works well. The other thing is role modeling. You can't underestimate how much the role modeling that students pick up from faculty. So I think it's both and. Now, we have a 3-semester course in ethics in all of our health professions programs because it's part of our Jesuit Catholic identity. So it's built in, which is good, but we still integrate it. And that's been kind of the argument about, clinical reasoning is, and we just, Jennifer Furs in a group, we just published a point of view in physical therapy. Is clinical reasoning a core competency or is it integrated? And there are two schools of thought on that.
Yeah.
So I
agree with you on the intentionality of things. Well, so when there's a course labeled manual therapy, then people reflect back and they say, oh, well, I took a manual therapy course and I learned about manual therapy and I got a certain grade. And now I can position myself in a manual therapy course for continuing education and learn more. Versus when things are just kind of, dispersed throughout the curriculum. And this is why I think things like pain education and cognitive behavioral therapy had to be really thought out and considered, because if you just kind of bury them within the curriculum, people don't necessarily, not everyone, but some students might not feel like they have enough confidence or competence in a certain area to then use it in practice or to reflect back on it when they start to practice.
But my observation has been, though, that it's too much. Oh, we have a course in pain science. It's like, well, wait a second here. What is that? And it's too much focused on the science aspect. On the mechanism. And that's not, I mean, why don't we have a course on chronic disease, right? Or population health, or so these things are all connected.
Right? They are. They're all very much connected. And when you look at, integrative approaches to healthcare these days, they're talking about, obviously, as you're talking about, bringing the humanities in with the arts as well as the science. Gail, it's been great speaking with you. I'm sure people are going to want to reach out to you and learn more about your work and maybe ask you some questions. How can people find you?
They can send me an email, Gail Jensen at Creighton.edu. I'm very good on email. I don't tweet. I'm not on Facebook. But I'm very good on email, and I love to hear from colleagues. So, we're all colleagues. I'm just like all the other physical therapists, and I care deeply about physical therapy. It's been a great profession for me, and that's my identity. I'm fond of sending all sorts of referrals, VIP referrals to our faculty practice because I use my observational skills.
Well, we appreciate your dedication to the profession, of course, and you can find all the links that we mentioned today on the show notes at the Integrative Pain Science Institute.com over on the podcast tab, and just scroll down to today's episode. Of course, you can reach out to Gail via her email, or if you can't find that email, you can just go to Creighton University and just search for Dr. Gail Jensen and she'll come up so you can reach out to her. Thank you for joining us this week and helping us kind of build out the importance of patient context and what that really matters. I'm Dr. Joe Tatta. It's been great being here with you, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.